Hello, good evening everyone. I am Dr. Kiran Pisekar, Assistant Professor in Cardiac Anesthesia at UN Mehta Institute. Today we are going to discuss about systemic venous anomalies under TE series for congenital heart disease. Systemic venous anomalies are important congenital conditions that can impact cardiac function and surgical planning. TE is a valuable imaging tool for the detailed assessment of these anomalies. We'll understand about the normal systemic venous anatomy on TE. We have right atrium which receives blood from the superior vena cava and inferior vena cava. Coronary sinus drains into the right atrium. TE can clearly delineate these structures and their connection. Now this is a table describing various venous structures which are draining into the respective chambers, that is RA, and in that first there is left innominate vein. Anatomically it is anterior and superior to ascending aorta and anterior to innominate artery origin in transverse spleen. In TE we can see visualize it in the upper esophageal aortic arch long axis view at 0 to 10 degrees while rotating left to right. In key imaging features of this, it is anterior to aortic arch in transverse spleen. Now we have superior vena cava which is right sided, anterior to right pulmonary artery, right of ascending aorta, and enters the RA near the septum. We can visualize this in mid-esophageal ascending aorta short axis view at 0 to 30 degree and mid-esophageal bicaval view at with multiplying angle at 90 to 110 degrees. We can see SVC entering into the RA anterior to RP. Inferior vena cava courses straight from the liver to RA, receives during this course it receives the hepatic veins. We can visualize IVC in transgastric IVC or hepatic view, which is a modified view, by advancing the probe from mid-esophageal bicaval view, and we'll get this structure at 80 to 100 degree multiplying angle. We can evaluate all hepatic veins including the posterior lobe hepatic vein. So posterior lobe hepatic vein can be missed, so we'll have to we need a clear attention while visualizing this. Then we'll come to how we'll distinguish between the right atrium and the left atrium. So usually the atrium is recognized by its appendage. So right atrial appendage is blunt, broad based, and it has eustachian valve which may mimic the septum. So eustachian valve is the valve at the ostium of the IVC, and it can mimic as a septum. We can visualize this at mid-esophageal bicaval view at 90 degree. IVC drains to RA, and right atrial appendage is best viewed in mid-esophageal bicaval view. Now left atrial appendage is a narrow finger-like structure, and we can visualize this in mid-esophageal two-chamber view at 80 to 100 degrees or antiflexion at 0 degrees. And then we have a coronary sinus which is posterior to left atrium, and it is visualized at mid-esophageal four-chamber view by retroflexion or mid-esophageal two-chamber view at 80 to 100 degree multiplying angle for long axis. So usually at mid-esophageal four-chamber view, when we'll advance the probe a little, we'll see a slit-like structure which is the coronary sinus. Now we can see it in short axis view in mid-esophageal four-chamber view and long axis in mid-esophageal two-chamber view. Now this is a TE image of mid-esophageal bicaval view. So here we can see this is the RA, this is the LA, this is the interatrial septum. We can see the SVC and IVC opening into the RA, and also we can see the coronary sinus opening into the RA. This is a modified transgastric hepatic view. Here we can see the IVC, and here it is coursing towards the RA. Meanwhile, there is hepatic vein which is opening into the IVC. So this structure we can achieve this structure at around 45 to 60 degrees by advancing the probe to the transgastric view and with the while rotating the probe anti-clockwise. Now again, these are all modified transgastric bicable views. Here we can see the SVC draining into the RA. Here this view is very is important so that we can align the Doppler beams in order to measure the gradient or across the SVC. So you can here we can see the waveform of the SVC in case when we find there is some obstruction or some turbulence at the SVC, we can measure the gradient in this field. Then we have this upper mid-esophageal ascending aorta short axis view. It is somewhat an upper esophageal view also. So here we can see the SVC, aorta, and this is the main pulmonary artery dividing into the LPA. So here we can see the superior vena cava in the short axis view. Again, as I have mentioned earlier, this is the right atrium and right atrial appendage, which is broad based and short, and here this is the LA with its appendage, which is finger like long. This is a major site for clot formation. So any abnormality is in the drainage, in the structure or drainage of the systemic vein can lead to anomalies. So common systemic venous anomalies are persistent left superior vena cava, interrupted inferior vena cava with azygous continuation, total or partial anomalous systemic venous drainage, bilateral or absent superior vena cava. Now prevalence of this is 0.3 to 0.4% in general population and 2.8 to 4.8% in congenital heart disease surgical cases. This is found by reviewing various data. Now what is the role of TE in systemic venous abnormalities? So we can do anatomical assessment, hemodynamic evaluation, and surgical or interventional guidance. In anatomical assessment, we can have a detailed visualization of systemic veins and connections. In hemodynamic evaluation, we can assess the flow patterns and shunts. And again, it is very important for the surgical and cath lab procedure point of view. Now, imaging techniques. So, first of all, we'll have to do a systemic scan. In that, we'll have to do a comprehensive TE examination, which involves getting all the views. So we'll have to systemically swipe through various planes, that is transgastric, mid esophageal, deep esophageal, and again deep transgastric and upper esophageal views as well. And by using the various views and we can visualize all these cardiac chambers, great vessels, and their connections. And we can use a color flow Doppler, which is again essential for assessing the blood flow direction, velocity, turbulence, which can help in identifying shunts and abnormal drainage patterns. We can use the pulse wave Doppler and continuous wave Doppler as well, depending upon the velocity of the structure which we want to visualize. So if the structure has a high velocity, we will use a continuous Doppler, and if the structure has low velocity, we will use a pulse wave Doppler. Again, for a if you want a velocity at specific area or at specific point, we will use a pulse wave Doppler. And again, we can use a saline contrast, which is again a very powerful technique. In this, we will use an agitated saline. So we'll again we can use albumin, can be used for in this technique. So albumin and so little air is mixed and it is agitated by and this agitated saline is injected, and after so this will basically create a micro bubbles, and we can later on acquire the T images. By recognizing the direction of these bubbles, we can identify the shunts and any anomalous drainages. So in most common is the persistent left superior vena cava. It is the left SVC persists in few individuals, and it drains into the coronary sinus or LA. So mostly it will drain into the coronary sinus. If it drains into LA, then patient may present as cyanosis. Now, what will be the TE finding in this? So there will be the presence of anomalous vein. A persistent tortuous vascular structure will be visualized alongside the descending aorta in the posterior mediastinum. Drainage, which will be draining into the coronary sinus. Because this is draining into the coronary sinus, there will be a added blood which is coming into coronary sinus, leading to its dilatation. So coronary sinus will be enlarged. We can again see the color flow, which will show continuous, often turbulent flow entering the coronary sinus. And again, by using the saline contrast, so if we have a intravenous IV cath in the left hand, in the left forearm, then we can directly inject the IV fluid or micro bubbles, and we can visualize if there are micro bubbles coming into the coronary sinus. That means there is a left SVC which is coming into the opening into the coronary sinus. Again, it can drain into the left atrium as well, which we can visualize. It will be seen directly entering the left atrium, often near the left upper pulmonary vein. And again, in color Doppler, we can see the turbulent non-oxygenated flow, which will be entering into the LA. We can use bubble study as well. Normally, the coronary sinus diameter is 5 mm to 9 mm, and it is measured 3 mm proximal to the coronary sinus ostium. It is dilated when it is more than 11 mm, according to various studies, and also there is they have given an index diameter of more than 1.02, which is calculated by dividing body surface area. Now this is a T image. So as I have told earlier, so we have acquired this T image by advancing the TE probe from mid-esophageal 4-chamber view. Here we can see a coronary sinus which is dilated. Here this is a mid-esophageal 4-chamber. This is a long axis. This is a long axis of the coronary sinus. This is the 4-chamber view. Coronary sinus, when dilated, it is seen in a short axis. Again, if you pull the probe a little bit from the 4-chamber view, we can see the coronary sinus as well as the left SVC. Again, as I told, this is the LA and this is the SVC. Here at in the mid-esophageal at around 80 degree, we can see the LSVC draining into the coronary sinus. We can see the flow of the coronary sinus, LSVC. Associated anomalies with this are ASD and VSD. Again, the second most common is interrupted IVC with azygous continuation. IVC can be interrupted with venous return redirected to the azygous vein. So here what happens is a segment of the IVC between the renal vein and the hepatic vein is interrupted, and that will be drained by the azygous vein. So azygous vein will be dilated and it will be draining into the SVC in this patient, and the hepatic veins will be directly draining into the RA. We can by using TE we can demonstrate the absence of IVC entering into the RA with prominent azygous vein. So TE findings will be absence or atresia of the hepatic part of IVC, dilated azygous or hemiazygous vein, which is directly draining into the SVC. So SVC will be dilated as well. And again, we can see the flow patterns. Color Doppler will show continuous flow with enlarged azygous or hemiazygous vein, and there will be absence of normal IVC-RA junction. Associated anomalies with this are heterotaxy syndromes, which can have asplenia or polysplenia, and left isomerism, which is out of this lecture. Clinical implications of this is seen in when the patient with single ventricle is posted for Glenn or Fontaine procedure. In this we cannot go ahead with the Fontaine procedure because the IVC is interrupted. So procedure which is Kawashima procedure is done. In this, BDG is done without ligating the azygos because because the IVC is interrupted, it drains into the azygos. So if we ligate the azygos vein in this patient, then it can be very dangerous. Now here this is the IVC hepatic vein, and it will be draining into the RA, where we can see that IVC is interrupted. This is the RA, but here there is interruption of the IVC. Hepatic part of the IVC is interrupted. Again here we can see the hepatic veins which are directly draining into the right RA. Now this is a T image demonstrating the azygos vein, which is very difficult to demonstrate. So here we will find the two vessels, in which one will be the descending aorta and the other will be the azygos vein, which is going towards the SVC. Here we can see the flow patterns of the, so pulse wave Doppler is used, and here one flow pattern is of the aorta and this is the flow pattern of the azygos. So aorta is usually in the flow will be caudally, and the azygos vein flow will be towards cranially in towards the SVC. Anomalous systemic venous drainage. Variations include anomalous drainage of SVC or IVC into the LA or pulmonary veins. Now T in this we can demonstrate that though there can be various T findings, including drainage of hepatic veins directly into the atria or other systemic vein, abnormal drainage of right superior vena cava, for example. So right superior vena cava can be found draining into the LA or for that matter into the pulmonary veins, which is very extreme, which is very rare. Again we can also find the venous aneurysms or stenosis. So T can visualize localized dilatation or narrowing of systemic veins. We can assess their size, location and impact on blood flow. Now here we can see the SVC. This is the SVC which is draining into the left atrium. Here again this is shows the, on color flow Doppler it shows the direction of the color. So here is our T probe. So it is towards the probe. So the blood is draining from the SVC to LA. Now again we can have bilateral or absent SVC. So TE visualization identifies both SVC and bridging veins and detects rare SVC agenesis. It influences surgical cannulation and pacing strategies. Now this is a TE image. It's actually a post-operative image. Here there is narrowing of the SVC, and that's why there is increase in the gradient, as we can see. Now there we can also identify coronary sinus septal defect in the coronary sinus septum, allowing communication between the LA and coronary sinus. So again this can give rise to cyanosis as well. So these are the common systemic anomalies and the role of TE. So persistent left SVC. So on TE we can visualize the course, drainage and associated anomalies. In case of interrupted IVC arch with IVC with the azygous continuation, we can identify absent hepatic IVC and dilated azygous vein. In case of total or partial anomalous venous drainage, we can detect abnormal drainage and assess the shunt severity. And in case of the bilateral SVC or absent SVC, we can visualize both SVC, bridging veins and drainage sites. Now these are the common TE views and the structures which we can visualize pertaining to the systemic venous system. So in mid-esophageal bicable view, we can visualize SVC, IVC, RA. It helps in assessing entry of systemic veins. In mid-esophageal 4-chamber view, we can visualize RA, LA, coronary sinus, and it helps in detecting the coronary sinus dilatation and septal defect. In mid-esophageal 2-chamber view, we can visualize LA, LV and coronary sinus, and we can visualize coronary sinus and its relations to LA. And in color flow Doppler imaging, venous patterns can be used, so basically for the shunts and gradients across the venous structures. In clinical implication, it can be used for diagnostic confirmation. So TE can definitely confirm the presence and precise anatomy of systemic venous anomalies, which can be missed on transthoracic imaging. Assessment of hemodynamic impact, it can determine the physiological consequence of the anomaly, such as shunting, volume overload, or obstruction. Now it is very important for the surgical planning. So detailed anatomical information provided by T is crucial for surgical planning, especially for cannulation to go on pump, and also for the planning of the surgical procedure. And it can also help in guiding intervention in cath lab procedure, also for going for going on peripheral bypass, for guiding the percutaneous interventions. Thank you.